Next up, we have Jamie Maier, and Jamie is joining us from 3M, where she is a senior UX researcher. And she's going to look at more sort of the macroeconomic level of the intersection of health and finance. So I think it's going to be very fascinating hearing from her. And Jamie, you're looking good, so take it away.
Awesome. Thanks so much, Amy. All right, so we'll start with some introductions, but like Amy said, today is really going to be looking at making the case for global healthcare systems, what they are and why they matter, and really comparing those different vantage points. So a little bit more about me. I see myself as a translator, and I like to look at complex information and spaces and taking that and really breaking it down into a way that different people can understand. So as a researcher, learning from the people who are served and then translating that back to designers for us to come up with design principles, or to the business side on different priorities, or to development on what those user stories need to be. I've spent about 2 years at 3M, all in healthcare. I'm on my second team though. And so I've done a little bit of everything from healthcare analytics tools, focusing on medical coding and medical billing. The last year and a half or so has all been on international projects, which is where this talk really comes from. I've also done things around medical devices, packaging, and then more patient-facing medical apps. And the majority of that is all qualitative research, whether we're going out and doing discovery type of work and learning about different situations and contexts, or if we are doing concept reviews or testing different prototypes. So first thing to touch on, though, is that 3M is more than just our Post-it notes. I think that's really one of our big ubiquitous items that everyone knows 3M for. But there are a lot of other things that we do, right? We have the N95 masks that have been in the headlines for the last year, sandpapers, adhesives. If you have a winter jacket, especially certain brands, there's a good chance it has Thinsulate in it, helping keep you warm. We also make a lot of the reflective materials that you see on street signs. But when we focus in on healthcare, I know a lot of us think of the front end of healthcare, where the clinicians are, the patients are, and that experience. And we do have a lot of products in that space. Techoderm is one that a lot of people are probably familiar with, Avogard, hand sanitizers, that type of thing. But we also make healthcare software that's really focused on that much more macro enterprise level. So you can think of this as the back end of healthcare. It's software that's used by our medical coders and medical billing, different quality departments. And it's not just used in the US, but it's used all over the world to support different regulatory processes, the same way as it is here, right? Medical coding is part of how our healthcare system here works, and that's no different in other parts of the world. And so that leads me to today's talk on global healthcare systems. So to give you a lay of the land, we're going to look at first what they are, and then how they compare to each other and why they matter and what impact they make on the different hospitals and organizations, as well as individuals. But before we do that, let's talk about some board games. And so we have 3 popular games here: Catan, Ticket to Ride, and Risk. And if you look at these at a 10,000-foot view, they're all games about territorial expansion, whether you're creating a settlement or trying to get from point A to point B, a massive continent, all of it is territorial expansion. But if I were to say to someone that, oh, Catan really is the same as Risk or Ticket to Ride, a lot of you would probably be up at arms, because these are very, very different games. Why? And that's really gets down to the context of each game. And so when we look at the context and the rules of these 3 different games, they completely change the strategy, the execution, and the way that the players are interacting with each other or not, right? So look at Catan and the bartering that's involved, the trading, the collaboration there for everyone to really try and build and grow their settlements, expand their territory in that way, is very, very different than what we see in Risk, where we have armies and it's much more about conquering and kind of using force to overwhelm certain areas, right? And that really is all coming back to that context and the rules of the game. When we look at healthcare, it's really no different than these games. We know a lot of the key elements. So first we have our players, or our stakeholders. So who are our people? These can be individuals like our patients and caregivers. They can also be larger organizations like hospitals or home health agencies. We have our payers or insurance companies that are involved, as well as larger government groups like the Centers for Medicare and Medicaid, or CMS. And then next we have the strategy, or in terms of healthcare, this is really our business case. And this one does more closely align with some of those entities like the hospitals and the larger insurance groups. Regardless of the type of healthcare system that you have, there's always a business case and processes for these groups. So in the US, some of those keywords here would be things like fee-for-service, billing, co-pays. Is this a billable procedure or a non-billable in this care setting? All of that goes back to that business case. And lastly, we have the execution, or the value. And there are tangible and intangible aspects to that value. So we have, from a tangible standpoint, different care settings. How is that care really being delivered? Where are you going? What are you receiving? Diagnoses, procedures, prescriptions. And then intangible, we have the patient satisfaction and the patient experience, and the quality. And while these are some of the key elements, what's really connecting them all is, as that glue, is the system. And that healthcare system is really what defines the game, and again, defines some of those rules. And our healthcare systems are made up of a lot of other components that really add in that complexity that I think we've heard from a lot of the talks the last couple of days. So we have different regulations for a public versus a private sector, different care settings and how care is executed, what is allowed to be done in those places, and different governing bodies such as CMS that are really making those rules and processes. We also see different requirements for data, technology, and then our medical coding and classification systems. And those elements are really what tied the rest of the system together and allow information to flow between groups. Now, what we're looking at here, and even a lot of the keywords in this, are all very US-centric. And that leads me to some of the global research efforts that we've had over the last couple of years. So the last 2 years or so, I've had the opportunity to lead global research on some of our existing products. And we worked with our internal teams, understanding the challenges that they were facing, as well as our external customers in all of these countries. So last February, just before the pandemic really started and everything shut down, we had two teams. One was in Australia, and myself and another colleague were in Europe. So we were in Germany, Belgium, and Italy, going and doing in-person research there. And then, of course, we did have to pivot to remote. And so all the work we've done with Canada and Saudi Arabia were remote. And this was all mainly generative discovery type research that we were doing. And our goal here, going back to those games, really was to learn the rules. And in this case, the rules are the regulatory environments. So who are the key healthcare players here? What are the regulations? How has this landscape changed over time? What does compliance look like? All of these things make up the legal rules of that healthcare system. And then the other piece was internationalization. And so looking at opportunities for as a company, what is our opportunity for strategic growth of new and existing products? But more importantly, how do we make a product locally relevant to our teams who are international and are trying to sell these different products, as well as our customers, and making sure that we are focusing on the right things. We also spent a lot of time looking at specific products and identifying pain points and opportunities, but that's a little nitty gritty for this talk, really looking at the higher level of the healthcare systems more in. So by the numbers, all of this translated into some massive MIRO boards. 17 research sessions collected nearly 4,000 different individual data points. So all the small little square post-it stickies you see on here are all individual data points. We worked with 22 hospitals, both public hospitals and private hospitals. So depending on the situation in the country, those looked very different. And so what you're seeing here is a small snippet of one country, and some of those findings that we went through and tagged and did our affinity mapping on to come up with insights. We also mapped these across looking at international insights and comparing countries to each other, and created lots of different artifacts. Now, all of that was really getting at the understanding of what global healthcare systems are. And so now that we had a good idea of what they were, next we'll talk about how they compare and why they matter. And these two things are really connected. So the first is that the type of healthcare system doesn't tell the whole story. And as an example here, we'll look at Canada and Italy. At face level, both of these are universal healthcare systems, meaning that your healthcare coverage is provided for all of its citizens, kind of free of charge. But like our board games, as you look down underneath the surface, things are very different in terms of how the healthcare systems are designed, what the regulations are, and then the execution. So in Canada, what we see is that all of our regulations, updates to things, and education and communication are all handled by one national entity. And there's really strict guidelines and clear communication on when changes are taking effect, what those are, and what requirements need to be met. Whereas in Italy, we see light national guidelines, regulations, and updates. And really the regional things, so think about their states, are much more important than the national, but they only provide vague guidance. Now, the impact of this. In Canada, because of how things are handled there, we see very highly accurate data, and they have a really strong understanding of community and patient need. To the extent that they can look at their population in a certain area, they can look at the medical coding. Okay, last year we had the need in this community for let's say 50 hip replacements. Next year, we predict that goes up to 55. And so they're able to look at that community need. They're able to set quotas and things like that because they have that data. A downside to that, though, is patients might have longer wait times in order to access more of these elective surgeries. Now, in Italy, we see a very outdated medical coding system, and there aren't really any incentives in place for hospitals to have highly accurate coding. Which means they have really poor data for studies. So we heard a lot of pain points here from people in quality departments where they weren't able to have the data they needed to run a study that they might want to run unless they were going out and really collecting it themselves. And we see little standardization across the different regions. So because each region is making their own rules and doing their own thing, we see that there's not standardization. So then looking at something at a national level is very hard. So the takeaway here really is that the system execution impacts the stakeholder interactions. So yes, Italy and Canada both have universal healthcare, but the execution of data and the medical coding that's happening completely changes how the hospitals are interacting with each other, as well as how they interact with regulatory bodies. And that's something that you see also trickling down to the patient and how they are interacting with care. Next thing that we see is that the system's design defines how it reacts under stress. And our example here will be Australia and Belgium. So in Australia, they have something called care type changes. So in the US, you go to the hospital, you have a length of stay, that's one thing. In Australia, it's divided into lots of smaller pieces. And those care type changes are really important because the funding for it comes out of different buckets called health funds. So it's important to get those care type changes right. In Belgium, we see there the situation is that the government provides little coding guidance and no auditing, which is great in some ways for any of you who have ever gone through a hospital auditing. It's not a fun process. So that means they have little fear of claims being denied for different medical coding reasons because there's not that auditing that's happening. So the impact here, if we go back to Australia and our care type changes, is that our care types often overlap, and the medical coders are the ones that really need to choose which bucket they think something falls into. And that has a really big impact on hospital reimbursement, as well as some of the data that's coming out of it and being able to use for comparative studies. Whereas in Belgium, because there's this lack of guidance and there's not a huge push for medical coding, we see that the hospitals are responsible for creating their own guidelines and rules and processes and education, and they have to keep themselves up to date on different regulatory changes that are happening. So the takeaway here is that our pain points are really tied to the system's design, and this one is really looking much more at hospitals. So when we look at Australia and Belgium, those different regulations really change, one, where those pain points exist, and then who is the one that's experiencing those and how they're absorbed into that system. Every system is going to have stress, but where it is really depends on how that system is created. And our last point here is that regulatory events can drastically change the rules of the game. And our example here is going to be Saudi Arabia. So over the last 5 years, Saudi Arabia has set forth what they call the Vision 2030, which is a massive infrastructure change project to look at how they can come up with more privatization and ways to really diversify their funding away from strictly oil. And one piece of that is healthcare. So the process they're going through right now is transitioning from a public healthcare space. So before we look at, there wasn't mandatory coding, there wasn't a lot of standardization, and there wasn't data submission across their nearly 300 public hospitals. As of this year, they've actually standardized their coding and data submission processes. So now everyone's data is looking the same. They're all required to submit the same thing using the same tools. And the goal of that in the near term is first to collect data and understand. So that instead of writing blank checks, the hospital payments will now be based on the different activities. So think of a fee-for-service type of model, or moving toward that, where at least we can now say, hey, you did 7 knee replacements this year, and here's how much you'll be paid per knee replacement. So that payment based on activities. Their longer-term goal here is to introduce insurance and a full revenue cycle reimbursement. This is a much longer-term plan, and again, the goal is to really diversify their government revenue streams. But this process is going to take a long time. But you can see where we went from today having full blank checks and not having that data and standardization, moving into something that is full insurance and reimbursement model, more similar to what we see in other countries like the United States. So again, we know that our healthcare systems can change, but they need coordinated, really exerted effort. Obviously the regulatory environment and government in Saudi Arabia, excuse me, is very different than in the US, but this is still going to be a multi-year transformation. The UAE underwent this, and it took them about 20 years to really go from full public into a more insurance-based model. And what we see here is that we have universities and private companies and public and private entities at all levels of government involved in this transformation. So where does that all leave us? Really, we know that healthcare systems are intrinsically tied to the regulatory environments, which define the process, value, and pain points. And this has vast impacts on the patients, hospitals, and also the companies that do business in healthcare. So we know that products that might be valuable in one context, in one country, might not be valuable in another at all, just because of where those incentives are and what things look like. They also might be valuable in a different country, but in a completely different way. Because again, that system is really what's defining the different incentives. So if you look at Saudi Arabia, again, if medical coding suddenly becomes a valuable piece of the puzzle because there's an incentive behind that, you see a lot more education programs being offered at universities, you see more jobs, you see whole new departments, all really springing up to support that effort, because now there's an incentive there and there's a value that the system is placing on that part. And then again, zooming in at those 3 key points, taking a closer look. Again, the system execution really impacts those interactions. And so here we're looking kind of who is holding that regulatory power, what level is most important? Is it a public? Is it a private? Is it a federal or more regional? And how do those groups interact with each other laterally and vertically? Next is that points are again tied to that systems design. And so I think we all know that healthcare is very complicated and there are a lot of challenges that we're trying to solve. And each of our speakers the last few days has called out different parts of those systems. Every country that we've looked at globally has had a different approach to solving the problem, and each one has their own benefits and pain points. But where those show up and who they show up for are different depending on the system and the stakeholder group that you're looking at. And lastly, again, we know that healthcare systems can change, but they take that, again, that coordinated, exerted effort. And the goal, what's interesting in Saudi Arabia, is really to look at the rest of the world and leapfrog a lot of the challenges that other countries have had as they implement their new system. So they're taking all these learnings that we've all struggled with in other places, both in the US and Europe and Australia and other countries in the Middle East, and using that to create what they think will be a more seamless healthcare system for their population. That is everything that I have for you today. If you have any questions, just feel free to send them over to me in the chat.
Thank you so much, Jamie. I think we do have time for a couple of questions. So please do ask in the chat, and I'll start with a question. I'm continuously fascinated as I learn more about health systems globally, with specific regard to public health and innovation. So in all of your research, what did you find interesting in terms of how the country handles investments in preventive health, public health, and handles investments in innovation? Because what I've heard anecdotally is that it's hard to invest in innovation, because when you invest in innovation, you're taking money away from prevention or providing care, and so it's hard to sort of know what bets to place. And so many have said, okay, yeah, it's great, we have this single payer universal health, but we still struggle to get awesome innovations out there, similar to our struggles in the US to get awesome innovations out there. So just curious what you've seen there.
Yeah, so because of the area that we were looking at, more that back end, we didn't look a lot at preventative type measures. We did talk a lot though about quality. And so think about quality studies that are being conducted, different quality measures, AHRQ measures, that type of thing we did learn a lot about. And something that we saw here was it really had to do more with the way that their system was set up. So let me think of an example. When we look at Germany, we didn't use them as an example in this presentation, but they have a much more robust way that they are keeping track of all of the data and gathering all of that. And what that means is they're not having to, their system is more seamless. So when you don't have a system that's as fragmented or as many overlaps or duplicates, you're able to spend that time in other things. And so having that stronger foundation allowed them to do other things like support other countries in their own quality studies and ways that they're collecting that data. If we take that spin kind of on innovation, right? Whereas if we go back to Italy, because their system is the way that it is and it's more outdated and they don't have that connection across things and able to see it, you're not even able to understand the current state, let alone move into something that is more futures thinking and more innovation focused.
Gotcha. We do have a question about whether the size of the country or the GDP would influence how the health system is designed and executed. So meaning, would a potentially richer country or larger country have a better health system? I mean, in the US, we are #1 in cost and 17th in outcomes. So we're not a poster child there, but any other thoughts?
I mean, I can't speak to that too much, right? Like all the healthcare systems that we looked at were in more developed countries, or those like Saudi Arabia, where they're undergoing a big transformation. And we're seeing something similar happening in Brazil, where they're now having a lot of regulatory events and really, let's say, updating and modernizing their healthcare systems. But I think the bigger piece though that we see more would relate to a talk yesterday afternoon that was looking at, and even the keynote yesterday morning, right, of looking at the population and the people that are actually being served, and what are their values and how do we approach things, right? Like we talked yesterday morning about the lifestyle changes that we see, and then that leading to some of the comorbidities that are so closely associated as risk factors for COVID, right? But that's much more population focused more than the system itself.
Okay. Gotcha. This was fantastic. Thank you so much, Jamie, for your work and for your talk. It's been a pleasure.
Yeah, thank you. Thanks for having me.
Absolutely.